Good evening, everyone. I want to welcome you to Queen's Speaking of Health lecture series. Tonight's lecture is called Diagnosing Dementia. My name is Lisa Sakia. I'm with Corporate Communications here at Queen's, and on behalf of the Queen's Health Systems, I want to welcome all of you this evening. And so, without any further ado, it is my privilege now to introduce our guest for this evening, Valisa Saunders. If you could stand, Valisa. She is a gerontological nurse practitioner here at the Queen's Medical Center. She earned her master's in nursing from the UCLA School of Nursing in 1983. 1 year later, she moved to Hawaii and was the first master's prepared geriatric nurse practitioner in the state. She has over 30 years of experience in her advanced practice role in geriatrics here in Honolulu. In 2008, she received the Clinician of the Year Award from the American Geriatric Society. This made her the first non-physician to receive this wonderful honor, so we are very fortunate to have her not only speaking here tonight, but here at the Queen's Medical Center. She is a member, yes, that's awesome! She is a member of the Queen's Inpatient Geriatric Consultation Team, where she assists teams from various services on the complex issues in older hospitalized patients. She's an instructor for the University of Hawaii Manoa School of Nursing and an adjunct faculty of the John A. Burns School of Medicine for the Department of Geriatric Medicine. Please join me in giving a warm welcome to Valisa Saunders.
Welcome, Ikomamai. It's a pleasure to be here tonight to talk about one of my favorite topics, one that I deal with a lot, on diagnosing dementia. Now, I'm not going to teach you how to diagnose dementia, but I'm hoping to reveal the many secrets and burning questions you may have. We'll take questions afterwards, but I'm hoping that we will answer a lot of them and have some discussion afterwards. I'm going to talk about, and one of the things that sparked me to have this talk, in addition to my professional experience, was experience with my own family, asking, now, what's the difference between Alzheimer's and dementia? Did anybody else have that question? So we're going to talk about what is dementia, what it's not, some of the most common types. I won't get into every type of dementia, but how is it diagnosed? And I think that's a mystery to people, and you'll see why. It's not easy. Just a little bit of mention about treatments. We're not going to talk too much about that. What are the care issues and planning for the future? Many of you stopped by our table at in the lobby about advanced healthcare directives and POLST. And if you have questions about that afterwards, I'd be happy to answer that as well. As I said, this is not a course to teach clinicians how to diagnose dementia. We certainly could not do that in 1 hour. And I know we have some health professionals in here. Can I just see a raise of hands? How many people are actually health professionals themselves or even retired? I know you're out there. That's okay. But you maybe have been working in other areas, but it is a really complicated topic, so we can't cover all the details, but hopefully we will answer your most burning questions and bring it to the forefront. As my tenure at Queen's has been about 1.5 years, a little over 1.5 years now, and working in the hospital, it's really become even more clear to me that it's not being diagnosed very early. And my hope would be that by raising awareness is that people would get assessment and diagnosis earlier. Not only the assessment and diagnosis, but taking care of other problems that may be impacting memory and function. So what is dementia? It's a brain disease. That's why I'm using pictures of the brain. It's a broad term for the loss of cognitive function, remembering and reasoning. It indicates it's an irreversible problem. Alzheimer's is the most common. So again, dementia is a broad term, and that's because usually we can't tell you in one visit what it is. It's a process. So there are some other causes, and I'll be talking about that later. I'm not going to name them right now. And it's also true that many people have a mixed dementia. There's more than one type going on. So what is cognitive deficits? What does that mean? So that talks about recent memory, the ability to learn and retain information and retain and retrieve newly acquired information. So when we talk about memory, we're talking about there's long-term memory, there's immediate, short-term, and delayed recall. And those are all a little bit different processes. Language is involved here, and I'm going to show you some pictures of brain parts, and so that's how we sort of sort out the clinical picture, what's going on with the brain. And there's visual spatial function problems in some people, and then executive function, which is actually seen early on, especially in Alzheimer's disease, where the higher level functions of executive planning are declining first. And people really don't notice this initially. Family members tend to take things over and not report it as a problem. And actually in my long career here, what we find is sometimes people that don't have family, actually the bank has been helping take over some of these functions. And the only problem with that is that they're still not getting the kind of assessment and attention they need for any medical problems that we can treat. So who gets dementia? Age is the biggest risk factor for getting dementia. So the older we get, the more common it is. There are a few types of genetic related dementias, but they're quite rare. Nearly 20% of people over the age of 80 will have or will be developing an irreversible dementia. There's a link at the bottom of this page. Let me just see if we can pull that up. I think we have internet in here. And this is a document from the Alzheimer's Association, so it'll be in the PDF file as well. And there's besides the facts and figures, they have lots of other information about Alzheimer's disease, and the Alzheimer's Disease Association, which also addresses other types of dementia, is a really good resource. There are many things on the internet that we can look up that will take you to all kinds of places in cyberspace that you don't really want to be. So for trusted information, the Alzheimer's Association and also the National Institutes of Health will have some good sites. Mayo Clinic also has some good information. But I would be very cautious about what you read on the internet about especially cures and supplements for Alzheimer's disease. A lot of it's snake oil. Okay, so how do we know what we're looking at? So we have a big process of how we assess dementia, and when we look at the clinical picture, we're trying to figure out, maybe what parts of the brains are affected. Scans don't really help us with that, although we do brain scans. The frontal lobe, which is up in the front, is what we call it's the filter, and it has to do with judgment and reasoning. So the memory may not be a problem in that part of the brain, but judgment and reasoning, higher level executive function may be affected there. The temporal lobe that's where memory and hallucinations will be formed. The hippocampus, particularly underneath the temporal lobe, is where the new memories are formed, and that's particularly affected in Alzheimer's disease. There's also the substantia nigra that's in this particular area. It's deeper in the brain than this picture shows you, where Parkinson's disease is the etiology there. The parietal lobe has to do with visual spatial skills and sensation, and then the back of the brain is the occipital lobe, and that's visual sensory information. That's a very rough overview of the function of the brain. There's a lot more things that have to be sorted out when we're trying to look at what is going on with the brain in terms of a dementia. I just gave you a second one so you can read the other details in the PDF file. So what dementia is not? If there's a metabolic problem, and we see this in the hospital, we call it delirium. When somebody's very ill and they have an infection that's very serious, they may become delirious. These infections actually rob them of oxygen to the brain, so they're not able to think straight. I mean, you've heard that term a lot of times probably, you're delirious, you're not thinking straight, right? But it's specifically a medical problem, and it can be infection, it can be imbalance of a variety of electrolytes, particularly sodium, calcium is another one, thyroid problems, particularly with that calcium, we may see hyperparathyroidism, and that can be a very life-threatening situation. It's not a delirium. Dementia is not a delirium, but delirium is what we're talking about. It's a clouding of the sensorium that can be caused by any of these above things, and it can result in psychosis. When we talk about psychosis, we're talking about hallucinations or delusions, and a lot of times they may be very scary for someone that has not experienced that. It's not the same as schizophrenia. They also have hallucinations and delusions, but it's being caused by a different problem in the brain. It's not the developmental disabilities or genetic problems such as mental retardation or Down syndrome, but it is true that many people with Down syndrome do develop what's essentially Alzheimer's disease, and it's usually 20 years earlier, 20 to 30 years earlier than when you would normally see in the adult population. These are the most common types of dementia, and I'm going to probably talk about Alzheimer's the most, although we see a lot of vascular dementia as well in our population, and especially in Hawaii where we have a lot of hypertension. Alzheimer's is by far the most common type of dementia. It accounts for 60 to 80% of these irreversible dementias. How many people know somebody with Alzheimer's disease? Statistically, there's not enough hands up. Or how many people have experienced a family member or adult, or parents that had Alzheimer's disease or something like dementia? So many of you have dealt with that, and it can be very difficult. It's very sad. So they have difficulty remembering recent conversations, names, or events. That's an early clinical symptom. And again, usually it's the higher level executive functions that we talk about that are lost first and often missed. Then it's short-term memory. Later on, orientation, meaning do you know what time, not only where you are or where you live, because that doesn't change very rapidly. So that's long-term memory, but knowing the day, date, and year. And as time goes on, the orientation becomes less and less. Later symptoms also include communication problems. And these are caused by what we think are brain changes, such as protein fragments of amyloid plaques and twisted strands of tau protein. Okay, fancy terms for what's happening at the cellular level in the brain. But the truth is we don't know everything. And when we diagnose dementias, and even when we follow the criteria that are set forth by the national guidelines, we're not always correct. But if it is something different, and someone asked me this question today, it's probably another irreversible dementia. But we'll talk about how we're going to sort out things that we can fix and things we can't. But scientists do believe now, and there's more and more, there's still things going on with the research about Alzheimer's and what can we do to cure this disease or prevent it altogether. They think it's a combination of genetic, lifestyle, and environmental factors that affect the brain over time. Less than 5% of the time, Alzheimer's is caused by a specific genetic change that virtually guarantees a person will develop the disease. This tends to be one that does run in families, and it tends to be a younger onset, but it is very rare. So the fact that you have a few people in your family that have Alzheimer's disease, especially when it's late onset, does not mean you are going to get it. But that's always a concern, and we are doing more work on the research in terms of genetic relationships, but we really don't know what to do with that information yet. And we do know some of the genes that are involved, but what it means if you have it, we don't know. Treatments for Alzheimer's disease are aimed at preserving acetylcholine. The main drug, how many of you heard of the drug called Aricept or donepezil? There are two others in that class called Razidine or galantamine and Exelon or rivastigmine. And these are drugs that prevent the enzyme that eats up acetylcholine from, they block that enzyme. So trying to preserve the acetylcholine that's there. At a certain point, we believe that there's really no more acetylcholine to preserve, and we may have more side effects in these people than benefit. So with those drugs, we may help slow down the disease, but we cannot cure the disease with it, and we don't make it better. We just hope to slow down the process. There's another drug called memantine. It's also known as Namenda, and this one blocks glutamate, which is a substance release that's damaging cells in the brain, causing the Alzheimer's disease. Supportive care is probably the most important thing that we can do for our patients with Alzheimer's disease. Making sure they're getting good medical care, health care, diets, and social stimulation. We also see a lot of depression in Alzheimer's and all types of dementias. As our brain ages, we see more and more depression as we age, but there's even more, the incidence is even higher in the dementias, in particular Alzheimer's and vascular dementias. And we can treat that dementia, and we can treat the depression. We do have drugs to treat the depression, and that can make people more functional. So if I'm not sure whether we've got dementia or depression, I'm going to treat the depression first, and I will see cognitive scores get better. Okay, that doesn't happen with the medications for Alzheimer's disease. We just hope to slow down the decline. But so when you see scores getting better, that means we're taking care of another problem, and they may be coexistent problems. This is just a depiction of where the damage is done in a couple different kinds of dementias. Alzheimer's disease, as you see here, and this is not a PET scan where you do see different colors. This is an MRI, and they're just showing with the colors where the damage is. So in Alzheimer's disease, it's primarily in the temporal lobes and a little bit in the parietal as well. There may be problems in the frontal lobe to different degrees, but with the fronto-temporal dementia, it's primarily in the frontal lobes and the temporal lobes. I have seen a patient with only in the temporal lobe, and when we did testing with him, we had a speech therapist come in and do language testing with him, and it was very helpful, and it showed us exactly what the CAT scans said, was that he had problems in his speech in the temporal areas. His frontal lobes were pretty spared. His memory was quite good, but he couldn't express himself, and he would get very frustrated and even agitated, possibly violent. So when we approached him, we would ask him to write things down, and I was amazed at how well he could write things in his memory, and he would write notes, and he would remember where he put them, which many of us with no dementia sometimes have a hard time doing, right? Okay, this is just another depiction of looking at the different lobes and where the functions are. Vascular dementia used to be called multi-infarct or post-stroke dementia. It's less common as a sole cause of dementia than Alzheimer's, but it's quite common. It's also one of the most common combinations with Alzheimer's as far as mixed dementias go. My experience is, and especially in the early stages, it can look very, very similar to Alzheimer's disease as far as the deficits are concerned. With bigger strokes, we may see more focal changes in function, not only their physical function, but in the brain function. And I've had a few patients with frontal strokes that filter, where reasoning and judgment are important, and those are very difficult to treat. And those are the people sometimes that I see in the psych unit. We take over medical management for the psychiatric elderly patients on the geriatric service. Okay. So we do brain scans. We pretty much do some kind of scan on everybody these days. When I went to graduate school, the mantra was that if they fit the classical history and physical exam, what we call no focal neurological problem. So it didn't look like there was any stroke symptoms, nothing neurological. We didn't really need to do any kind of a brain scan. And we only had CAT scans anyway. We didn't have MRIs. Over the years, we find that it's very helpful. And we do have people, almost everybody gets a CAT scan, and we really do like to get an MRI. And what that's going to do is help rule out other problems or guide treatment, whether it's drugs for Alzheimer's or other issues. It's going to guide our treatment. And I'm going to give you an example of that in a few minutes. Risk factors for vascular dementia, again, increasing age. but your history includes cardiac things. Heart attacks, strokes or mini strokes, atherosclerosis, high cholesterol. High blood pressure is one of the biggest concerns. Diabetes is also a very high concern. Smoking increases your risk, obesity, and atrial fibrillation, which is usually known as the rapid irregular heartbeat of the little chambers on the top of the heart. And some of those people are put on Coumadin or some of the newer drugs to prevent blood clotting and hopefully avoid strokes. The treatment for vascular dementia is controlling all of those conditions. So controlling diabetes to a reasonable level. If we have 80, 90-year-olds, we don't want to make their blood sugars so low they fall down. We see a lot of those in the hospital too. Sometimes medications are needed for other symptoms caused by strokes and infarcts. So it may be, they have a lot of depression incidents, and sometimes they even need other kinds of drugs to help with some of the behavioral symptoms. Lewy body dementia. How many people have heard of Lewy body dementia? Quite a few. Okay, I think people are becoming a little bit more aware. And we're still really learning about Lewy body and also everything on the Parkinson's disease spectrum. Okay? Typical Parkinson's disease, people don't initially have memory problems usually. They often start their disease in their 50s or 60s. It can be later, but it's not that common. Many of them do develop a dementia later. At least 30%, it's only related to the Parkinson's disease, but the incidence I've seen as high as 70% with Parkinson's disease. Now, Lewy body is not exactly the same as Parkinson's, but there's some very similar areas of the brain that are affected. They typically don't have memory problems in the beginning, although they can, but they're much more likely to have vivid visual hallucinations in the very beginning. Potentially they can have auditory hallucinations, but I have never seen that. It's usually the visual hallucinations. And they may have Parkinsonian type symptoms, but that usually develops a little bit later. So this is a whole list of things that you'll see in the Lewy body dementia. And the reason I put a little picture here of the penguin is just to illustrate how vivid some of these hallucinations are. I had a patient that told me when I asked him, sometimes as we get older, we're on medications, our minds play tricks on us, and you might see things that aren't really there. Has that ever happened to you? And he described to me the penguins that he would see on his bed. And he had never told anybody. He happened to have a family member with him, and as he was describing these penguins on his bed, they had the look of disbelief on their face. They had never heard about it. He knew they weren't real, and they did not bother him. He liked his penguins. So we don't give antipsychotics to people having hallucinations that don't bother them, and that's true with anybody. It's very common. Another lady I had saw pink roses. Most of the time it will be people, but it'll tend to be little people. Whereas schizophrenics, who also have visual hallucinations, tend to see bigger things, big monsters, and they're very frightened, and they're bothered by those hallucinations. Lewy body patients usually are not. If they are disturbed, we may use antipsychotics very sparingly. We use very small doses, and we're very careful about what kind we use, because we will induce Parkinson's symptoms in these patients if we use the wrong kind of antipsychotics. So this is where it's not on the top, it's inside the brain, where there's an area very similar to the Parkinson's disease where we see the damage in the brain. Actually, we don't see that on our scans either. That would only be on autopsy, and that's true for most of these diseases. With vascular dementias, we do see damage in the brain that we can see on MRIs. We'll see either actual strokes, chronic microvascular ischemic disease, and sometimes they'll tell us it's their lacunar infarcts, and that means it was an old little stroke. This is just another depiction of some of the things in the brain, and this little blue piece, that's the hippocampus, and this is the substantia nigra. So the hippocampus, again, is in Alzheimer's disease. We definitely know that's impaired with making new memories for Alzheimer's patients, and the substantia nigra for Parkinson's disease and possibly Lewy body. Then we have fronto-temporal lobar degeneration. We usually just call it FTD, fronto-temporal dementia. Anybody familiar with this disease? Has anyone been experienced having somebody with fronto-temporal dementia? Okay, imagine now it's the frontal lobe. What does the frontal lobe do? Reasoning, judgment, kind of tempering our tempers. So these are the people that may have really bizarre new behaviors. They can have been a stellar citizen and suddenly they're stealing or they're doing things you would never expect of this person. And we always want to be get these people evaluated because there may be something going on medically, and while it's usually not a reversible, the sooner we get the right kind of help, and there are some treatments we can do with medications that can help with the behaviors. There are variants of the frontal-temporal lobe dementias. Some of you have heard of Pick's disease, and that's based on autopsy studies. There's specific cell changes in the brain. And some people have this primary progressive aphasia, and they lose their ability, their speech ability. They may understand, they still may have receptive abilities, but they can't speak as well, and that can be very frustrating. It's like a lot of stroke patients too. This is only about 10% of dementia patients, but it's very profound. Unlike Alzheimer's, memory is typically spared in the early stages of the disease. So it can be very confusing. They can talk a good story, they just can't deal with difficult situations, and they're impulses. They're very impulsive. These typically are a younger onset as well. So now to the title of our talk, how do we diagnose it? The most important thing is the history. Now, when we learn how to do history and physicals and diagnosing, we're told that the history is 80% of the diagnosis. And in Alzheimer's disease, it's probably even more than that. So we want to have somebody to come with someone that's experiencing problems. We want to hear what they've noticed. We have some checklists that they can check off, and it's really amazing how many times I see people that have some memory impairment, and I start noticing things, and the family member will tell me, she's fine, there's no problem, she does everything herself, she's sharp, she knows who I am. But really when you get the history, the checklist will say things like, do they repeat sentences, do they forget dates, do they misplace things and they can't retrace their steps? And we have about 20 things on the checklist, and there's be a lot of positives. And then as we talk about it, it's becoming more to their awareness that, yeah, there have been some problems. And one of the things I will always ask is, so who takes care of the finances? Maybe the son took it over. And so, well, how long have you been doing that? About 5 years. Who did it before that? Well, she did it. She did it herself. So, well, why did you take over? Well, there were problems. So those are the functions when we talk about executive function that was changing. But we're a very kind culture here, and we tend to take over and excuse it. Well, she's getting older, so we want to take off the burden from her. But they may be the early stages, and there are some studies that are saying that actually the early changes of Alzheimer's may be starting even 20 years before we actually diagnose somebody. So the history from family is very important, and anything they can tell us. We do have standardized testing we do for mental status. Sometimes it's hard to do standardized testing with people. It makes them anxious, and we don't want to call it a test, but we want to do an assessment. So we do the best we can. We do have a variety, we call them. One is the Montreal Cognitive Assessment. They have a variety of forms, and they have developed a really good one that is for people with really low level of education. And that's very helpful for people that, for whatever reason, only went to 3rd grade or 5th grade. And I had a patient here recently from Arkansas that was the case. And I didn't think he had any dementia, but he didn't do well on standardized tests. I found out about this other one, and I used that. He did very well. His baseline was going out hunting for 3 or 4 days at a time with his dogs, and he knew how to get back and functioned very well. But his reading level wasn't very good. There's no blood test that will tell us if somebody has dementia of any type. So it's always, we call it a diagnosis of exclusion, and we're looking for these functional criteria, mental status criteria, and ruling out things in the brain, making sure there's no infections, tumors, looking for those strokes, whatever will give us some clues, and looking at further evaluations. Maybe we do want to have them see a speech therapist, but we'll look at more speech things. And we also want to rule out depression. So we have a variety of types of scales that we use to assess depression in older people. And it's the Alzheimer's Association and the National Institutes on Aging that publish the guidelines that we follow in terms of what are the criteria, do they meet the criteria at this time? So with the history, we want to know, well, when did people start noticing features? And again, most of the time in the hospital, when I ask about it, they'll say, oh, she was fine until she came into the hospital. So we have to circle back and start doing it a different way. Okay, so, and we want to know, is it gradual or is it stepwise? And what we mean by that is with Alzheimer's, it tends to be a very insidious, gradual decline. There's nothing, and that's why it's hard to spot. Whereas with vascular dementia, often it might be a stepwise decline. Not always. If it's just small chronic vessel ischemic disease, it may be as insidious as Alzheimer's disease. But when you do get this history of stepwise, meaning all of a sudden she was not doing well, they weren't moving, they had some slurry speech, but then she was fine. It was just a TIA and she's fine. She recovered completely. But they never really come back totally to the baseline. So that's what we mean by stepwise. Changes in behavior or personality. You see that in most types of dementia. And what did that look like? Well, she used to be the life of the party. And now she doesn't even really like to go out. Chronic diseases will give us some hints too. Again, we mentioned the risk factors for vascular dementia, especially diabetes, high blood pressure, atrial fibrillation. Those are probably the biggest ones. Family history for dementia may or may not be helpful, or mental illness. As well as the patients with Down syndrome. Okay, they do develop early dementias. We also see more development of dementia in chronic schizophrenics. We don't know the cellular basis for that, but that seems to be true. We're also always looking for metabolic problems. We mentioned the electrolytes, thyroid problems. Also, we cause a lot of problems with medications. And particularly things like, and I would include alcohol there. And although there is one type of dementia that is solely associated with alcohol, not every alcoholic is going to have what we call Wernicke's dementia. They may have just the vascular dementia from the problems with drinking. But the benzodiazepines are another class of drug that it looks like they don't only cause behavioral problems, they frankly cause depression if people have been taking these drugs chronically for a long time. And that's what we tend to see. Not as common in Hawaii anymore, I think, than when I first started. And I don't think it's ever been as common here, but it does happen. You also have to be sure that you know what you're taking over the counter. There's a lot of drugs on the market that we think of, they must be safe. It's over the counter, it's got to be really safe. The one that I really am concerned about the most is, I want you to know about Tylenol PM. Anybody know what's in Tylenol PM? Myra. I knew Myra would know that. Myra's a nurse I used to work with. Benadryl. Now, I don't want to trash Benadryl completely because Benadryl can be a life-saving drug. If you have an allergic reaction that's causing real problems, you want to take Benadryl. But to use it for sleep, especially in older people, I have seen older people, including my mother, hallucinate with Benadryl. It can make them not only confused, it can make them hallucinate. It also makes people constipated, drowsy. They can have falls. So it's not a benign drug. And it's not, I don't recommend it for sleep. I mean, young people probably aren't going to be as affected as older people, but that's my spiel. And there's a lot of other antihistamine drugs that are over the counter. So Benadryl is antihistamine, classic, very antihistamine, very anticholinergic. But your cold medications over the counter, chlorpheniramines in these drugs, brompheniramine. They are also antihistamines, and they can cause problems in older people with same side effects. So, how can you help with the diagnosis? And family members are key. And on the Alzheimer's Association website, they have this wonderful document. It's called 10 Early Signs and Symptoms of Alzheimer's. Now again, remember, the Alzheimer's Association also represents other related disorders, any dementias. They'll help you with that. But so there's descriptions on here. I'm not going to read them to you, but memory loss, challenges in planning, difficulty completing familiar tasks, confusion, so on. And they also have a little worksheet that you can use. And if either you or a family member are having these kinds of problems, please take it with you to the medical appointments. Primary care physicians or nurse practitioners, they have a really hard job. There's not enough people out there doing primary care. They don't have enough time to do everything they would really like to do for older people. But if you bring in some written notes, and especially if it's in this consistent format, it can really help with this process, and you can really be part of the whole diagnosis process. So I talked about this a little bit already, but I want to make sure, has anyone heard of the mini-cog? Okay, maybe you haven't. But a lot of providers will do this. It's called the mini-cog, and it's a screening tool. It's just three words, clock drawing, and the recall of the 3 words. And that's a screening test. So if you already have problems or there's any fail there, that's not your test. Further evaluation needs to be made. These standardized tests, such as the Montreal Cognitive Assessment, we also have one called SLUMS. Doesn't mean it's a ghetto. It's the St. Louis University Mental Status Assessment. That's another good one. We typically don't use the mini mental state exam. That's an older one we used, and it's not as sensitive. It's reliable, but it's not as sensitive as these newer tests. The difficulty comes in when you have people with varying levels of education, culture, language. But if we've done a lot of them over the years, we might have some experience there that can help with kind of interpreting those things. And sometimes we do need to bring in an interpreter, but even an interpreter that speaks Spanish from one part of the world doesn't understand the culture from another part of the world. So it's always a challenge. What are we looking for on the mental status exam? Obviously, short-term memory is one thing that we're looking for, but we also want to know if their attention is intact. Because if somebody is sick and delirious, they have a hard time paying attention. And even if there's nothing wrong with their memory, they won't remember. Anxiety will do that as well. Has anyone in this room ever experienced test anxiety? Yeah, you knew it, but you're so anxious you can't remember the answer. Kind of like when I blanked out a few minutes ago, right? So we're looking at, long-term memory is very different. So often we'll ask family members about how their memory is. Oh, fine, and but it's selective. She can remember everything about the past, but she can't remember that I told her yesterday that we're going to the doctor today. That's because short-term memory is a very different part of the brain than long-term memory. I think it turns out that emotional memory may be different too. She never forgot that one thing. She never forgot that grudge. So in these standardized tests, we're looking at immediate, and that's for attention, short-term, and delayed recall. We'll do some pen and paper drawings, the clock drawings. We have objects that will show them that will help us sort of sort out some of these things. Language assessments, abstractions. Give them a couple of words in a category, and how are these two things alike? Recognitions of patterns or animals, and orientation. And temporal orientation is one that we are looking at. So they may know where they can, if I ask them where they live, they know where they live. They've always lived there. They know their address, and they don't forget their address or their zip code. They might know their phone number. Of course, they might not have that phone anymore. It's probably been unplugged for 10 years. But they now are starting to lose track of the day and the date, and then the year. So it kind of goes in what's long-term and what's short-term. So look for those patterns. Mood testing. I don't like to say, I'm going to test you for depression, because that's really not what we're looking for. Well, we might see depression, and we need to screen them and do some further assessment on that. And depression and anxiety sometimes are really linked together, right? But we do have different tools to do that. Some of these are question and answer or yes and no's. We read them a question and they answer yes or no about how they feel about that, and we don't want them to think about it too much. Sometimes as dementia advances, they're really not going to be able to do that. We have some observational scales that we can use. One's called the PHQ-9, and that has an observational scale, and then there's a Cornell scale for depression and dementia. And I find that a very useful tool, not only for assessing their mood and behaviors, as also some education for caregivers about, well, if you do see these behaviors, maybe you need to bring them back and we need to talk about what's going on with them. When I worked in a clinic before, there was a geriatric consultation clinic, and we'd see them just for the consult, but we'd work with them for about a year while we start them on medications, and we, check them up every 2 months and see how they're doing with that. No side effects. How are they maintaining their cognition a little bit better? And after a year, I'd say, well, you don't need to come back for a year. Like, oh my God, what do you mean? What are we going to do? I said, well, if you have problems, you can bring them back. Well, they didn't really know what to bring them back for. So I use that scale for that as well. It's things like they're losing weight, their appetite's bad, their sleep patterns are different, they're losing, they're becoming more withdrawn, behavioral problems, and maybe we can help sort out that. The physical exam is important. Again, the history is the most important, but we certainly do need to do our physical exam. The cognitive testing is part of that, a thorough neurological exam to see what we see and see if that matches up with the history and E&E scans. The blood tests, we do check electrolytes, thyroid function. There's vitamin deficiencies, most prominently vitamin B12 and vitamin D. Now, I don't want you to go run out and take all these supplements, okay? Vitamin B12 is a water-soluble vitamin, and it comes out of your system very easily. But vitamin D, which originally we thought was just really important in bone function, turns out it's also important in muscle function and also in cognitive function. But loading up on vitamin D can be a mistake because it's a fat-soluble vitamin, and that can stay around for a long, long time. So that can be overdosed. So don't do that without some direction. Again, the scans we talked about. In some rare cases, lumbar puncture may be needed to rule out something going on in the central nervous system. Care issues and planning for the future. And that's one of the reasons we had the table out there with my team of advanced practice nurses talking about advanced healthcare directives and the provider orders for life-sustaining treatment. So it's important to talk about what you want ahead of time so that when you do lose the ability to make complex medical decisions, and we always want to involve people in their decisions to the extent that they can, and we want to name somebody that we really trust and understands our value system to be what we call a durable power of attorney for healthcare. Caregivers also need to realize that they're going to need to take care of themselves. If you try to take care of somebody all by yourself, 24 hours a day with no help, your health is going to suffer, and then that's no good for the other person as well. So we need to plan for the future. And we do see a lot of depression in caregivers that don't take care of themselves. So that's not a good thing. Then their physical health can suffer as well. So here's some resources. I mentioned the Alzheimer's Association already. Kokua Mau is our local hospice and palliative organization, and they house a lot of information that's really good. They have our State of Hawaii forms for advanced directives, the PULSE form, which is the provider orders for life-sustaining treatment. And then we have the Alzheimer's Association. There's a national one, and then the NIA site that mentioned earlier. We also have the University of Hawaii Elder Law Program. You might want to look that one up if you have some questions about some legal things. And I think they run some clinics once in a while. It's a great program up there, too. And that's it for now, but we'll entertain questions. I think Lisa's going to help.
Yeah, if you have a question, just raise your hand and one of us will come down.
We had somebody over here.
Yeah, could you raise your hand?
Someone's going to come down with the microphone. There we go.
Hi. Do you have any behavioral care tips? Like I heard on NPR one point, they were talking about 10 things you shouldn't do when caring for Alzheimer's patients, such as If they are at home and they're saying, I want to go home, what do you say? Or if they say something wrong, don't argue with them. Or
That's a great question.
Busy.
The question is about tips on managing some of the behavioral symptoms in dementia. That's the actual term that we use. They're saying, I want to go home. Maybe they're already home. Are they already home? Or even if they're not. So there's a book by a woman called Jo Huey. It's called Alzheimer's, Help and Hope. It's a very short read, and I've bought this off of Amazon many times, and she has the most wonderful 10 commandments on there. And one of the 10 commandments is, don't argue, just agree. And don't reason with somebody with Alzheimer's disease. You distract them. The other thing you can do, though, is if someone is saying, I want to go home, you can ask them, instead of saying, you're already home, or no, you can't go home, you must really miss your home. Or maybe they're saying, I'm going to go see my mother. She's 85 years old and she wants to see her mother. So you can say, you must really miss your mother. Let them reminisce. Let them talk about their feelings. People with Alzheimer's disease still have feelings. The person is still there. So if we can acknowledge their feelings, I think you might find that very helpful. There was a workshop today here too by Teepa Snow, and she's a really great resource if you want to look up I'm sure she has things on the internet. She's a national speaker, and she uses a lot of touch. And one of the tips that she taught my team today was, instead of trying to feed someone, if you're having trouble feeding them, you take their hand and put their hand in your hand so that to them it looks like you're their auxiliary, you're the extension cord, but it's actually them. So their brain gets it. The brain understands their hand, but they're more frightened when things are coming from somebody else. So there's a lot of things that we can do behaviorally if we just watch ourselves. We've got an agenda, but they don't understand what's going on. So we have to respond to their feelings, and tactile touch is very helpful with them too. Thank you for that question. Anything else?
We have a question from upstairs. We have some people upstairs because there are so many people here this evening. Is dementia overly diagnosed in the elderly population?
The question is, dementia overly diagnosed in the elderly population? Well, I think you probably hear the term dementia a lot because we don't always know for a while, unless you really have someone that can spend the time in multiple visits to tease out what kind of dementia do we have, then in that sense, I think it's overused. But the incidence of dementia as we get older does climb significantly. And I think it's probably more common than people actually think.
Okay, I saw a question down here.
I saw somebody over here.
While James is going there, we'll get this one.
There are some statistics that by the age of 85, over 40% of people may have an irreversible dementia starting. Now, that doesn't mean you're going to be, unable to function at that time.
With the various etiologies that you mentioned, isn't it important to try to really make the differential diagnosis between like Alzheimer's versus like some of the vascular dementia? They are chronic, but they are self-limited. If you have multiple small strokes, you don't progress. Whereas Alzheimer's is a progressive brain neuronal death. So that you would think that for the caretakers, at certain time as you follow, it would really be nice to know what they're going to be like 2 years down the road, 3 years down the road.
Yeah. So the question here, and that's a very good point, that we do want to know as accurately as possible. Now, sometimes we're wrong, and when we get brain studies, there were more than one type of dementia, but we do want to be as accurate as possible because it will guide treatment. Giving somebody with only vascular dementia drugs for Alzheimer's disease usually is not very helpful and can cause side effects and even cardiac side effects. And with Alzheimer's, we want to know if that's really probably the diagnosis so that we can use the medications, especially early in the disease. Typically later in the disease, they're not very helpful. And certainly something like Lewy body disease, we want to be very careful And we want people to know that that's what they have, because there are going to be a number of drugs that are going to make them worse. So it will guide treatment. And as far as prognosis goes, yes, Alzheimer's is going to continue to progress. And the issue about vascular, is, if we can halt it, can we? It's time limited, I think you used the word. It's, well, not time limited, but they do tend to progress, but it tends to be more erratic. We have a lot less ability to predict the course. Now, if someone's been living alone and not controlling their blood pressure because they weren't taking their medications and they were having problems, and then they have a caregiving situation where they get their medications regularly, they're getting regular activity, good diets, they may stabilize longer, but we don't really know. And again, there are many times that we have a mixed situation with Alzheimer's and vascular. But yes, we would like to know the differential as closely as possible, but it's not always really feasible. A lot of these diseases we're not going to know until we do a biopsy of the brain.
I think my case is a little bit special, different. As you can see, I'm not a native speaker. You can see that my accent or that. I think I'm a candidate for this disease because I have acquired all this language when I came to the United States, but now the language is not easy anymore. I keep forgetting, or I know one time, long time ago I used, but I cannot remember that word. So is this the acquiring stage, or I have the onset of this disease already? I'm just worrying. So I talked with my doctor. He said, "Oh, just keep reading, and quote and look up the SAT test, this vocabulary or that." But I'm a working person. My even colleagues here, yeah. So I don't have that kind of time. But
Okay, now we have somebody really worried.
yeah, I wish I could test. Yeah,
And I don't know if you could hear her, but she's describing a situation where she's not a native English speaker, but she lives here, and she has been speaking English for probably a number of years. Over 20 years? Yeah, over 20 years. But now she feels like she's forgetting some of her English is not as proficient. So that could be an early sign, but I would certainly be looking for some other issues, medical issues. Certainly if you're having problems with a metabolic problem or an illness, a thyroid problem, that the first thing that's going to go is going to be your English, because people that are, second language speakers, yes, later on they definitely revert to their primary language more readily. But we could also be looking at something like an anxiety or depression. And so those are that's something you need to take to your healthcare provider and advise them. You are having this concern that you're losing your second language ability, and is it affecting your memory? And you want to have that checked out. And that's not an easy task, but I wouldn't assume it's Alzheimer's. I would never assume it's Alzheimer's. I would be able to check out. Those would be in my differential. I don't know you, so I don't know, but I would want you to be checked out thoroughly for the possibility of depression, for the possibility of metabolic problems, thyroid disease, vitamin deficiencies. You deserve a good, thorough evaluation. Yes.
Thank you very much for sharing this very informative talk. Could you go more into the prevention and or postponement of onset? I know things like obesity.
I'm sorry, onset? What onset? Early onset?
Yeah, to prevent or to postpone the onset. I mean, living a healthy lifestyle is obviously helpful, and alcohol, you mentioned obesity, high cholesterol, et cetera. But is there anything proactive? Could you go into that as to what one can do to postpone or to prevent dementia?
Okay, he's wanting to find out if we have any more tips on postponing or preventing the onset of dementias. That's the $64 million question, and certainly, we don't really have a magic bullet at this point. And I will warn you that there are a lot of people that are willing to sell you all kinds of things out there to prevent it. And you've heard about ginkgo biloba, that's been up and down, and it's been disproved. And then you hear another study, and it's because anything that's not controlled, that's not approved by the FDA, they can say whatever they want, really. They can make claims about things that are not drugs, and because they're supplements or foods. Again, I would stick with good lifestyle, avoiding unnatural things, avoiding too many supplements. I think get advice from your providers about what you should do. Fresh fruits and vegetables, more and more. And we do have a researcher here in Hawaii, Dr. Brad Wilcox, who's involved in longevity studies, and he does have something that's going to clinical trials that is being touted now, and you can find it at Costco, a supplement called astaxanthin. It seems to activate the FOXP03 gene that the Okinawans seem to be have very prevalent and long lives, but it also is related to their diet. And so they eat a lot of fresh fruits and vegetables, and particularly cruciferous vegetables, maybe, the really dark green and leafy things may be more healthy than plain iceberg lettuce. Everyone said, well, I'm eating my salad, it's iceberg, but there's not much nutrients in there. But there really is no magic bullet other than healthy lifestyle, exercise, controlling your blood pressure, controlling diabetes, trying to prevent those diseases from, not everybody can prevent them, but we don't have anything right now that's going to prevent Alzheimer's completely that we know of. But there are a number of things being tested at the national level in clinical trials that will or will not be approved by the FDA, and I think that's really important that we stick to the science.
Hi. I see individual with early signs of dementia, and we see it progressing a lot faster. At what point do you decide that maybe 24-hour healthcare is the proper way to go for this individual? When do you decide?
I don't think there's enough, if we're talking about cognitive tests, so the question here is about when do we decide that somebody can no longer be on their own and they need 24-hour care? And that's a very tough question because it's not easy. But we have to look at a variety of things. And so sometimes it's basic baseline function of people. What's their functional level? It's not just one thing. I mean, even if they are very, very functional physically, at some point, are they still eating? I mean, if people are losing weight because they're not eating, because they forget, that's an issue. But you could say, well, we're giving them food, we bring in lunch and breakfast and dinner, but if they're losing weight, it's still a problem, and there may be some other medical problems. We also have to look at safety issues. So if they take medications, who's monitoring that? Because sometimes they're not taking it, something they really need, or they're taking too much, they're not taking it correctly, or they may be wandering. So you have to really look at the individual situation to see what is safe. And it's, not everybody has the same home living in situation. So someone that lives in a neighborhood where they've got neighbors and they know them and there's no stairs and they don't take medications, they just function well, you may not have to worry about it as much as someone that has a home that they sleep upstairs and they're starting to fall and there's nobody around. That's a problem. And so it depends on the setting, depends on their cognition, depends on their care needs.
Okay, we have time for one more question.
If family history is one of the factors, is it true that Alzheimer's from the maternal line is more significant than Alzheimer's from the paternal side?
Okay, the question is about hereditary Alzheimer's, especially if it comes more from the maternal side. It's more inherited from the maternal side than the paternal side. I don't think that's really true. I think the issue is that women tend to live longer. We have a longer life expectancy, period. So the incidence is higher in women. So we do see, so you may not see it in the men, even though they may have developed it later on, but the average life expectancy in Hawaii for men is 78, and it's about 84 plus for women. So the incidence will be higher in women. And in those age groups, I mean, if you're over 80, the chances of really inheriting it is low. So like 5% that you're going to have the inherited type. I have seen a family like that where there was a large family and they were pretty old, but there were like 6 brothers, and I think they all had Alzheimer's disease. And they had long life. So I don't know of any statistics that say it's more inherited from the maternal side. I could be wrong, but I just don't know that statistic. I think we just have to be careful how we look at incidence based on life expectancy in men and women, because it is different.
Okay, let's give Valisa Saunders another round of applause. Thank you.
Thank you.
I also want to thank our volunteers this evening, James Liu and Steve Takayama of Mid-Pacific Institute, the best school in the world. And also Janice Kekoa, who filled in for a volunteer who couldn't be with us tonight. Again, I told you we recorded this lecture this evening. We're going to post it on our Queen's YouTube channel. If you registered online, we're going to send you that link 1 to 2 weeks from now, along with Valisa's PDF of her PowerPoint. If you're not on our Speaking of Health list, we have an email list outside. You can just fill it in with your name and your email address. Next month's lecture is going to be on sepsis. An infection can lead to sepsis, and are you at risk? And it's about that a simple cut or a flu could lead to a life-threatening condition called sepsis. You're going to learn about the risks, the symptoms, how it can lead to tissue damage and organ failure and even death. I also want to let you know we're still working it out, but in September we're going to have one on caregiving with Dr. Jessica Berry, so you might want to take that down. We don't have it up yet on our website, but that's coming up in September for our Speaking of Health. Okay, for your parking tickets, don't forget to get them validated outside with Erin, and turn in your evaluation forms, please, and have a great evening. Thank you and good night.